Good afternoon and welcome to today's webinar, The Importance of Venous Anatomy for the Reflux Ultrasound Examination. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will be open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and the American College of Phlebology. And now I would like to introduce today's guest speaker, Dr. Nick Morrison. Dr. Morrison is the co-founder and medical director of Morrison Training Institute and the Morrison Vein Institute. Having maintained a private general surgical practice for 23 years, Dr. Morrison and his wife, Terry, established the Morrison Vein Institute in 1996. He is the president-elect of the International Union of Phlebology, past president of the American College of Phlebology, chairman of the American College of Phlebology Foundation, and editor-in-chief of Phlebology Forum. With that said, I will now turn the webinar over to today's speaker, Dr. Nick Morrison.
Thanks very much. As you can see from that first slide, this is not Mickey Mouse. That's the famous Mickey Mouse seen on a lot of different scans, but that's not me. I'm Nick Morrison, and I saw it on the previous slide that you can actually go for technical support. Believe me, you do not want to come to me for technical support. I am a technical dinosaur. So use that tab to go. Don't ask me to do it. That's my disclosure slide, and I always put these on a beautiful scene from Arizona. That's my home state. That's Antelope Canyon up in Arizona, and the disclosures are on the right-hand side. This is going to look a little complicated, but I don't want you to get lost in the details. So I'm going to be pointing out some things on these slides that are really pretty busy, and I'll just give you a little bit of commentary on some of the more important ones. But there has been a nomenclature change in venous with respect to the veins in the lower extremity. This has been an attempt to try to make these names more anatomic than attached to people's names, so they're a little clearer. So we'll start with the nomenclature of the deep veins. And in the thigh, the common femoral vein remains the same, but it's now the femoral vein. It used to be the superficial femoral vein. Now it's the femoral vein, and the reason is if you see a thrombus in the common femoral vein or the femoral vein and report it as superficial femoral vein, that indicates maybe to the practitioner that this is a superficial thrombosis and not actually a deep thrombosis of significance. So superficial femoral vein is gone. Now it's the femoral vein. I just point out these medial circumflex femoral and lateral circumflex femoral veins. You'll see these in the groin, and if you see them, that's an indication that if they are refluxing, if you see them at all and they are enlarged, that's an indication that there's another source besides the saphenous source for the problem. And you can tell now from this commentary that I'm going to be relating clinical pictures to these names sometimes just as we go along. So those are the veins in the leg and the foot. So throughout this presentation, if I can remember to do so, I will be referring to the thigh and the leg. So the thigh is the portion of the lower extremity above the knee. The leg is the portion of the extremity from the knee down to the foot. So this is no longer, we're trying to get away from calf and say leg. That medial gastrocnemius vein, that's something that you may see enlarged on occasion, and the reason it's enlarged often is that the patient is athletic or pretty active, and so that is not necessarily an abnormal vein when you do see it enlarged. And now this is the nomenclature of the superficial veins, and we'll go through these in a little more detail. So the great saphenous vein is no longer the greater or the long saphenous vein. The reason for the change was that if an acronym is LSV, that can either refer to the long saphenous vein or to the lesser saphenous vein. Now it becomes the great saphenous vein, or GSV. We'll go into the saphenofemoral junction in a bit more detail in a little while. But I pointed out because the definition of that junction has been expanded, and it's important for you to know that when you're doing a scan and developing a treatment plan, particularly. The subterminal valve now becomes the preterminal valve. So there's a terminal valve and the preterminal valve. The anterior accessory of the great saphenous veins and the posterior accessory of the great saphenous veins, those have changed, so they're not just anterior accessory or posterior accessory. These occur both in the thigh and the leg, so I'll explain that a little bit later, but you need to understand that there is an anterior accessory of the great saphenous vein and posterior accessory of the great saphenous vein if these are seen within the saphenous sheath. And I'll show you that in a little while. Now, in the leg, talk about the small saphenous vein that is no longer the lesser or the short. It's now the small saphenous vein. The saphenopopliteal junction is also changing in terms of its location and scope, and we'll talk about that in just a little. There's something called the cranial extension of the saphenous vein, which is a very common occurrence. And I'll show you images and some diagrams of that extension. So there's very frequently an extension of the small saphenous vein that does not terminate or takes off from where the vein dives into the deep system to join the popliteal vein, if it does so. And if it goes to a femoral vein, terminates in a femoral vein or up in the gluteal area, that's a thigh extension. If it curves around posterior medially and joins the great saphenous vein, that is called the vein of Giacomini. So this is one of the few veins that we left names associated with them. And the perforating veins, there have been some changes here. And you can see the thigh perforator veins. There's a perforator vein called the Hock perforator. That one has changed. Now becomes the posterolateral thigh perforator vein. The reason that's important is it's not uncommon to see patients who have a series of telangiectasias or reticular veins in the lateral aspect of the thigh, and not uncommonly it's coming from that perforator vein directly from the deep system. It's not associated with the saphenous or other superficial veins. Thigh perforators can also include that Dodd perforator and the Hunterian perforator. Those have now changed to be a little more anatomic. They're now called posterior medial thigh perforator, or the perforator vein of the femoral canal. And getting away from those named perforators and trying to describe them a little bit more anatomically. leg perforators, so down in what we call the calf. So the leg perforators, the Boyd, Sherman, and Cockett perforators, those names are all going to be replaced by the medial leg perforator vein, the paratibial perforator vein, and the posterior tibial perforator veins, those Cockett, formerly Cockett's, the upper, middle, and lower posterior tibial perforator veins. And these are the foot perforators that can become important, especially if you have a case of someone who develops a foot perforator thrombosis. So, to repeat, the Hunterian, Dodd, Boyd, Sherman, Cockett, all of those names are going to be changed. I'll show you an image that fix these. And this is kind of complicated, but if you'll just bear with me, I'll show you what's changed. So the Sherman and Boyd perforator, that's gone. Now it becomes the paratibial perforator veins. Pockets just to the left of that, on, and now becomes the posterior tibial perforator vein, upper, middle, and lower. The Hunterian perforator, or the Dodds perforator, that's gone and becomes the posterior medial thigh perforator vein. Anterior is gone and now becomes perforator vein of the femoral canal. And finally, on the right-hand side over there, that Hock perforator is gone and, as I said, becomes the posterolateral thigh perforator vein. Seems a little bit complicated, but you'll get used to using these terms, and they're much more anatomic, and people can understand them. And the importance is that we all speak the same language, so we know what areas of the body we're talking about across the world. And then finally, the pelvic veins. These are all of the named pelvic veins. Some of them of importance are the ovarian and the testicular veins. Another name for these are the gonadal veins. These have become important if you have a patient with pelvic vein insufficiency and be able to identify those and name those. And then these veins lower down, the rectal veins, the gluteal veins, those are all indicators. If you have insufficiency in those veins, that's a strong indication that the patient's symptoms may not just be from saphenous insufficiency in the leg. They actually may be originating up in the perineum or the pelvis and coming all the way down into the leg. And then the other perforator veins you can see on that the other pelvic veins you can see on the right-hand side. That inferior superficial epigastric vein, that's important because it's the entrance of that vein into the saphenous vein up near the saphenofemoral junction that is important when we're contemplating doing an ablation procedure on the great saphenous vein. And so we have to preserve flow through that vein in order to have a successful procedure without thrombus extension into the common femoral vein. And now a bit about general terminology. It's important that we understand these terms because when you're reviewing the literature or you're generating a report, you need to be able to, again, speak a common language. So agenesis simply means the complete absence of a vein or a segment of a vein. Aplasia indicates the lack of development of a vein or a segment of vein. May be present but small in size, and in fact its structure is similar to that seen in the embryo. Hypoplasia is the incomplete development of a vein, less severe in degree than aplasia, and a hypoplastic vein has a reduced caliber with a normal structure. Proximal indicates closer to the heart. Distal indicates further away from the heart. So when we describe, for example, the proximal great saphenous vein, we know that's the upper portion, if you will. And the distal portion of that great saphenous vein is further away from the heart, so it's down in the leg. Dysplasia indicates a complex abnormality of development of vein or a group of veins that greatly differs from the normal conditions in the size, the structure, and the connections, and they're pretty obvious when you see them on ultrasound. Atrophy indicates a decrease in size or a wasting away of a normally developed vein following some sort of degenerative process. All changes are different, and that's according to the nature of that degenerative process. Venous aneurysm indicates a localized dilation of a venous segment with a caliber that increases 50% over the surrounding normal vein. Venomegalia designates diffuse dilation of one or more of the veins with a caliber increase 50% greater than that surrounding normal vein. Here's what I was talking about with the saphenofemoral junction and the saphenopopliteal junction. From a strict anatomic sense, the junction really should be where those small saphenous or the great saphenous connect to the femoral and the popliteal veins, right at the terminal valve. But because of pathophysiology, they were trying to extend the anatomic concept of junction. So from recent papers on the pathophysiology, these junctions are going to be expanded to extend on the saphenous trunk from the pre-terminal valve up to the saphenofemoral junction, located some 3 to 5 centimeters below that terminal valve. As well, in the common femoral and femoral veins, this will be from the junction will be from the suprasaphenic valve and the infrasaphenic valve. So as you can see, we've expanded considerably, and I'll show you a little illustration of that. Expanded considerably the implication of the saphenopopliteal and saphenofemoral junctions because of the pathophysiology and the things that we find and the things that we use actually in terms of developing a treatment plan. So, anatomy of the leg veins. 2 systems of veins, the deep and the superficial. It actually may be a little easier to think of these as for the physiology of the lower extremity with compartments and drainages. So let's talk about 4 venous networks. First of all, there's the superficial venous compartment, saphenous venous compartment, perforator veins, and the deep venous compartment. Talk about these in detail. I'll go through these all. Deep venous compartment includes intermuscular veins and intramuscular veins. Intramuscular veins in the thigh are the femoral vein and the deep femoral vein down to the popliteal vein, and then into the leg, the tibial veins and the perineal veins. Muscular are the gastrocnemius and the soleal muscular veins. This is an example, and one thing you should get used to saying is that veins have a confluence. They don't bifurcate, they have a confluence. So in other words, the flow is directed proximally toward the heart, and veins come together, they don't split apart. Confluence, not bifurcation, something to get used to saying. This is an image of a duplicated femoral vein, which is very common. If you look for it, you'll find it quite commonly. Most of the time, almost all of the time, there will be a smaller component and a larger component. And it's that smaller component that if you do develop a femoral vein thrombosis, it will often be in that smaller component. This is an image of a transverse image of the intramuscular and intramuscular veins, the lower extremity. There is the small saphenous vein, which obviously is not a deep vein, but it's used for orientation. There are gastrocnemius veins and the popliteal vein. Intramuscular and the popliteal, intramuscular those gastrocnemius veins. A longitudinal image of the popliteal vein with the valve that you can see. And by the way, that's probably not a normal valve. It appears as though they are quite thickened, and you may not be seeing all of the valve, but it's probably not a normal valve. Now, the veins within the saphenous compartment, will include the great saphenous vein, the anterior accessory great saphenous vein in either the thigh or the leg, posterior accessory great saphenous vein, again, either in the thigh or the leg, small saphenous vein, and the thigh extension or the Giacomini vein. Start with the great saphenous vein, and that video clip is showing you a nice picture of the terminal and the pre-terminal valves. I hope that images nicely for you, but the saphenous junction, so it includes the great saphenous vein from the terminal to the pre-terminal valves, and then they're not easily seen on this clip, but it'll also include the supra and the infrasaphenic veins in the deep system. Some of the most important tributaries of that saphenofemoral junction include the superficial circumflex iliac, the superficial epigastric, and the superficial external pudendal. You see reverse flow in either the circumflex or the external pudendal. That's a strong indication that you may be dealing with some pelvic insufficiency, not just saphenous insufficiency. That's actually the superficial epigastric, and it's below that vein, the entrance of that vein, that you want to start an ablation procedure. This is the expanded definition of the saphenofemoral or the saphenopopliteal junction. You can see that on the left image. You can see the suprasaphenic valve, the terminal valve at the great saphenous vein, the pre-terminal valve in the great saphenous vein, and then on that right image, the infrasaphenic vein. So that whole thing we're going to call the saphenofemoral junction. It's similar in the saphenopopliteal junction. One of the important things to remember is you see all these tributaries that are coming between the posterior and between the terminal valve and the pre-terminal valve. Those tributaries, if there's reflux in those tributaries and you have a competent competent terminal valve, that's a very strong indication that this is a problem originating in the pelvis or the perineum and not coming through that saphenofemoral junction or the terminal valve. Great saphenous anatomy, so you can see this is a transverse image where the great saphenous vein is contained in what is commonly referred to as the Egyptian eye. So there is the overlying superficial fascia and the underlying muscular fascia. So that's the great saphenous vein. It has to be in that compartment to be able to be called the great saphenous vein. That's a great saphenous vein that is actually leaving. You can see it piercing through the fascia and forming a superficial vein that can no longer be called the great saphenous vein. That is not to say that you can't treat that vein if that's a major source for the reflux, but that's not called, once it exits fascia, that saphenous compartment. It's no longer the great saphenous vein. I noticed on this image that there appears to be what looks like a clot that's in that great saphenous vein. That is not a clot. That's artifact. Looks like a clot. So the great saphenous vein anatomy is quite variable, and it's necessary to understand these variabilities in order to properly evaluate and diagnose treatment, which is going to directly lead to much better treatment modality. These are some of the anatomic variations. You can see on the left the three images comprise about 70% of what you'll find. Two images on the right, about 30%. That first one, A, is a single great saphenous vein all the way along the fascial compartment. That's not terribly common. Everybody thinks it should be always the case, and it's not at all. The next one, B, represents a true duplication of the great saphenous vein. It's both stay within that fascial compartment. Again, pretty uncommon. And then on the right, on that C, a single great saphenous vein associated with major superficial tributaries. That's the most common in this category. D is the great saphenous vein and anterior accessory saphenous vein, each in their separate fascial compartments. And then E is the short length of the great saphenous vein that emerges into a superficial layer, very commonly seen. And that's the great saphenous vein that leaves the saphenous compartment, and you can see it in transverse. It's within the compartment, and then it's gone, and it appears as though that saphenous compartment is now empty. So that would be an aplastic great saphenous vein, or at best a hypoplastic great saphenous vein. So on the image on the right, you can see that the superficial tributary, which may be functioning as the major great saphenous vein. Vein is hypoplastic, seen within the saphenous compartment. That vein may be normal. It's certainly of normal size, and that may be a normal vein. And if you decide to ablate the great saphenous vein and leave that tributary, that's not going to treat the patient's disease process very well at all. Also, as you can see, it may indicate, if it's hypoplastic or missing, it may indicate that the patient has had some sort of previous treatment, such as thermal ablation or a stripping procedure. Great saphenous vein below the knee is sometimes difficult to identify. The best way to do it is to identify the tibia and the medial gastrocnemius muscles. This is called the angle sign, the tibial-gastroc angle sign. And you can see that it lies, if you find the gastroc muscle and the tibia, just above that in that angle should be the great saphenous vein in the leg. Accessory great saphenous vein, again, can be in the thigh or the leg or both. That's the posterior accessory great saphenous vein, formerly known as the posterior arch vein, or Leonardo's vein. It's now the posterior accessory if it's within the saphenous sheath. The transverse image up at the groin showing posterior accessory great saphenous vein on the left, great saphenous vein, and the anterior accessory great saphenous vein, all of them seen in this one image. The anterior accessory may have some variations in terms of its termination. It often will terminate with the great saphenous vein at the saphenofemoral junction. It sometimes will join the great saphenous vein a little bit distally. It may join the common femoral vein itself, and it may be the major outflow, so that the great saphenous vein is either hypoplastic or isn't even there, and that's what's joining the Again, that alignment sign for the anterior accessory up in the thigh. So this is, if I can show you this. So it's shown. So anterior accessory great saphenous vein is directly in line with the common femoral vein, and the great saphenous vein is off medial to that. That's called the alignment sign. Posterior accessory great saphenous vein, you can see it over there, posterior and to the posterior to the great saphenous vein. In this image, it's a longitudinal image. You see the small saphenous vein that is about to enter the popliteal vein, but the vein of Giacomini. In this case, it's a vein of Giacomini, again, because it connects with the great saphenous vein in the posterior medial thigh. Taking off, that's a pretty normal sized vein of Giacomini. I have another image that will show you of a distinctly abnormal vein of Giacomini. Up at the groin, again, I talked about that superficial epigastric vein. The importance of that vein is that you want to maintain flow. If you're going to thermally or use some ablation method for the great saphenous vein, most practitioners will preserve flow through that superficial epigastric vein, which probably allows drainage of the abdominal wall and the perineum. When we did high ligation and stripping procedures, we sacrificed that vein, among others, And what we saw was the development later on of neovascularity, because you have frustrated the drainage from the abdominal wall and the perineum, and now the blood has to get around somehow, and it creates this nest of tributaries in the region of the saphenofemoral junction, trying to get around what you did. So again, starting the treatment below the entrance to the superficial of the gastric is the key for an ablation procedure of the great saphenous vein. Saphenopopliteal junction includes all of these. The saphenous vein, you can see that. Small saphenous vein, that's the image on the right-hand side. The great saphenous tributaries that can drain into the small saphenous. Popliteal perforators are not uncommon, and gastroc perforators are very common. And pelvic veins you can trace sometimes pelvic veins all the way from the buttocks down to the small saphenous vein, causing reflux into that distal small saphenous vein. Just because you see insufficiency of the small saphenous vein, it doesn't mean it's coming through the saphenopopliteal junction. It may be originating elsewhere. And this is that image I talked about, the saphenopopliteal junction with that very large vein of Giacomini. That's a strong indication that the reflux is coming down the vein of Giacomini and proceeds on down into the small saphenous vein sometimes. Sometimes it just dumps into the popliteal vein. A little clip of an abnormal saphenofemoral junction. See the valve there. And then down, that's a very enlarged vein, or appears to be a very enlarged vein. That's the superficial of the gastric vein. I wanted to show you, if you see a vein that's this large, you really need to think that this may well be an incompetent vein. And I'm going to show you on this clip the small saphenous vein from the distal calf up to the saphenofemoral junction, lying between the two heads of the gastrocnemius muscle. When it stops, you can see it at the top. It enlarges right before it gets there, and it's shown between the two gastrocnemius muscle heads. Small saphenous vein has a variety of terminations. The thigh extension is present in most limbs, and it's a continuation of the small saphenous vein. The small saphenous may join the popliteal vein or deep veins at a higher level. There actually may be no connection to deep veins. That's quite common. The small saphenous vein may be in the midline, medial, or lateral to the midline. And the gastrocnemius veins may join the popliteal vein, the upper small saphenous, or a confluence of the saphenopopliteal junction. This is a nice image of the small saphenous entering gastrocnemius veins, which then enter the popliteal vein. So on the right, again, the pointer's a little slow, so I can't show you, but on the right, Anyway, on the right-hand side of that image, you can see that the small saphenous vein is entering with the gastrocnemius veins, and then all go to the common channel into the popliteal vein. This is a transverse image that's showing exactly the same thing. That is, a small saphenous vein enters the gastrocnemius veins, and then they dump into the popliteal vein. Thigh extension variations, as I said, this is a very common situation. Most of the time that thigh extension goes up into the great saphenous vein as the vein of Giacomini. If it doesn't join the great saphenous vein, it is a thigh extension or cranial extension of the small saphenous vein. It can also enter the common femoral or femoral vein up higher, or perforator into the thigh or gluteal veins. Thigh extension that's measured in the transverse view. You can see it within that deep compartment. Or the saphenous compartment, you can see that there's overlying fascia and underlying fascia. Simply a spectral Doppler showing reflux in that thigh extension. And then the superficial compartment veins. These are collaterals and saphenous tributaries that are superficial to that saphenous fascia. These are some obvious clinical examples of those superficial compartment veins. This is somewhat less obvious. These are often seen only on ultrasound. This is a clip showing the small saphenous vein. You can see the sural nerve, and again, I can't show you, but it's just to the left of the vein. Then you can see the tributaries that enter and leave that small saphenous compartment. So that's superficial on top of the saphenous fascia. And an incompetent infragluteal vein coming from the perineum down the posterior thigh and entering the saphenous vein. This is not uncommon. So you can tell the anatomy is a lot more complicated than we ever imagined. Pathophysiology is likewise very not well understood. This is a spectral Doppler of that incompetent posterior thigh perforator. Tributary. And then an infragluteal perforator. You can see it on the kind of the left side of that screen. It comes down right there. Now, the veins that you see in the middle of the screen top, those are obviously non-saphenous in origin. That is, those are coming from the perineum, likely from the pelvic insufficiency, either gonadal veins that are incompetent or pelvic varices, periuterine varices that extend down the leg, and in some cases that saphenous vein is completely competent above where those enter, and then it's incompetent below. This is another example of some posterior leg veins that appear to be coming from the small saphenous. In fact, these are those veins that come from the great saphenous vein out into tributaries and then back into the small saphenous vein distally, producing reflux in that small saphenous. The implication of that is if you treat only that small saphenous vein or the great saphenous vein, you're probably going to get a recurrence pretty quickly. And this is a trans-perineal image of incompetent tributaries. If you do a trans-perineal ultrasound, you should expect to not see much in the way of veins. They're pretty small, but this is an obvious case of incompetent tributaries in the perineum. You know you have to look further up to find the source for these. And finally, perforator veins of the leg. Now, as you know, perforator veins are designed to drain from the superficial veins through fascia into the deep system. And the valve normally directs flow from superficial to deep. Example of all the perforators, there are perhaps as many as 150 perforators in the thigh and the leg, something that's not well appreciated by people who are new to the field. Thigh perforators generally pass from the great saphenous vein to the femoral vein. Calf perforators can pass from the great, the small, or major tributaries into the calf muscle venous plexuses. In order of frequency, the calf perforators are most frequent in the medial aspect of the calf or leg, posterior, lateral, and then anterior. These are some examples of the perforator veins. The image on top is a very large perforator. The one in the center is likewise a large perforator. And on the clip, on the video clip, that's a small saphenous vein with a perforator. We are much more respectful of perforators than we used to be. We used to think that perforators were, if they were enlarged and had reverse flow, they were absolutely abnormal and you should be treated. That we find that that's not correct, that many of these incompetent perforators will regain competency after treatment of the saphenous incompetence. This is an example of a long thigh perforator. You can see in the left-hand side image. The importance of this is it's real easy as you're trying to do a thermal ablation procedure. When you're passing your guide wire, you can see on that right image that the wire is actually down into the perforator. And if you don't recognize that, you can end up treating either the perforator or even worse, the deep venous system with thermal ablation. So, in conclusion, I would tell you that you ought to be aware of variable anatomy in the thigh and the leg. Venous anatomy is quite variable. And if you don't understand the venous anatomy in the leg, you may encounter some difficulties you might not have anticipated. So, I would like to acknowledge Diana Newhart, President of CompuDiagnostics, for her collaboration and these images. Thank you for your attention, and that's my email address in the lower left. If you want to get a hold of me, you're welcome to. I monitor that about 100 times a day.
Okay. Thank you, Dr. Morrison. At this time, we will begin the Q&A session. We also ask that all of your questions be relevant to the information in today's webinar. Questions about accreditation should be directed to IAC by phone or email following the webinar. Okay, from IAC Vascular Testing and Vein Center, I'd like to introduce Marge Hutchison, IAC Director of Accreditation, and Laura Henson, our clinical specialist. Marge and Laura will assist Dr. Morrison with the Q&A session today. Marge, would you like to start us off?
Yes, thank you, Kelly. Thanks, Dr. Morrison. The veins are much more complicated than people give them credit for, I think. They don't really appreciate all those variabilities going on there. The first question is, what about duplicate GSVs?
Yeah, a truly duplicated great saphenous vein is very uncommon. Most people will mistake the two veins that they see in the thigh. One is superficial, the other is within the saphenous sheath, and they interpret that as a duplicated great saphenous vein. That's wrong. If you call it a duplicated great saphenous vein, both have to lie within that saphenous compartment, and it can't be the anterior accessory or the posterior accessory.
All right. Can you briefly explain the difference from the terminal valve and the pre-terminal valve?
Sure. The terminal valve, it occurs right at the entrance of the great saphenous vein or the small saphenous vein into the common femoral or the popliteal vein. Pre-terminal valve lies 3 to 5 centimeters inferior to that, and the importance in the great saphenous vein, as I pointed out, the importance of that pre-terminal valve is if you have a competent terminal valve and an incompetent pre-terminal valve, the flow is likely coming out of the pelvis or the other portions, not the saphenofemoral junction, and that has really important implications in terms of treatment, because if you simply blindly eliminate the great saphenous vein and haven't addressed those tributaries that are incompetent, your recurrences are going to be early and frequent.
Okay, thank you. When is it important to describe the findings of gastrocnemius or soleal veins?
Obviously, certainly if there's a thrombosis in those veins. Otherwise, for a routine report, I'm not sure it's terribly germane to developing a treatment plan. I'm not sure that they really need to be described in all cases, but certainly in the case of a thrombosis. If they are very large in size, say greater than 10 millimeters in size, that should be described, because that may signal that there's something else going on, perhaps a proximal obstruction or a venous malformation.
All right. A similar question. When is it important to describe findings of accessory veins or double femoral vein?
Yeah, first of all, the duplicated femoral vein, it's important to describe that primarily because, as I said earlier in the talk, there are typically two limbs, a smaller and a larger limb, and if you do a procedure, the patient can develop a thrombus in a smaller limb that's frequently missed actually on follow-up examinations, and those are DVTs and can propagate or can embolize. So if you see it on the routine scan early on, that should be reported, just because of the implications if it thromboses afterward. The other question, Marge, was?
Oh boy, I moved.
Yeah, the anterior accessory saphenous vein. If it's certainly, it should be always mentioned, but the importance is if there is reflux incompetence in that anterior accessory, that should be noted, because that's going to be important in terms of planning that treatment, because you need to eliminate that refluxing anterior accessory as well as the grate if it's also incompetent.
All right, here's an interesting question. What are the risks of RFA ablation without complete knowledge of the venous anatomy?
I showed you a couple of instances. So the first one is if you haven't identified a perforator and you simply advance your wire and it goes into a perforator, you could end up trying to do an ablation procedure on the deep system, and that's considered bad form. In terms of other things, there are other implications, but that superficial epigastric vein, it's really important to know where that is. The general rule is for thermal ablations, you start 2 centimeters below the saphenofemoral junction. Well, the entrance of that superficial epigastric vein is variable, and it might be 2 centimeters below the saphenofemoral junction, and if you start there, you may well occlude that superficial epigastric, and again, block drainage of the abdominal wall and the perineum.
Okay, let's see. What about, how does compression or Valsalva, or either proximal or distal compression and Valsalva, how does that affect the veins, and what's the recommended way to do that?
Those are some technical aspects that I actually should leave to Diana for her next talk, but let me just briefly say that Valsalva maneuvers are used for the upper portion of the veins, and compression release are used for the lower portion. So anything distal to, say, the mid to proximal thigh should probably be done with compression release. One thing to note is if you're dealing with people who are very large, it may be difficult to produce adequate compression to get a good study. And there are some compression devices, some cuffs that can be used that are automatic inflator and deflator, so that may give you a little bit better idea of what's going on with that patient.
Okay, and that's a good segue into announcing our next webinar in the series, which is going to be performing the duplex ultrasound exam. Do you have any thoughts about investigating and documenting pelvic congestion syndrome?
Yeah, absolutely. This is far more common than is generally appreciated as a source for leg symptoms. So if a woman presents with leg symptoms, but in further questioning you also identify that she has pelvic symptoms, pelvic pain, dyspareunia, that sort of thing, or had large perineal varices during pregnancies, that's an indication that the Saphenous system may not be the only source for the patient's leg symptoms and reflux, that it may well be above. So it's estimated that as between 15 and 30% of women who come in, of premenopausal women who present with leg symptoms, may have a pelvic or a perineal source for their leg symptoms, either in addition to or instead of leg vein incompetence.
All right. Well, there are more questions, but they're not really related to anatomy, so we will deal with those off the webinar. So as far as anatomy questions, that pretty much answers the ones that we have here. I'll let Kelly finish it out here.
Hang on just a second, March. I just wanted to say that men can have pelvic insufficiency as well, and that'll be manifested by varicoceles. So scrotal varicoceles will be apparent, and that same process. That is, they have gonadal incompetence coming down and producing a varicocele. However, most of those are less commonly symptomatic than are females.
Okay. Thanks again, everyone, and a very special thank you to Dr. Morrison for today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. And just a reminder that today's webinar is session 2 in a 4-part series. Join us again on Wednesday, September 16th for session 3, Important Technical Aspects of the Venous Reflux Examination with Diana Newhart. Visit the IAC website to register. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, The Importance of Venous Anatomy for the Reflux Ultrasound Examination. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.